One, please start, ma'am. We are live.
Namaskar and good evening, everyone. I welcome you all for today's webinar on Oncology Update 2023. And with immense pleasure, I would like to invite Dr. Sunil Kumar Gupta, who is Director in HOD, Hemato, Medical Oncology and Bone Marrow Transplant, Venkateshwar Hospital, Delhi, for the welcome and introductory note and to set the ball rolling. Over to you, sir.
Thank you. Very good evening, dear friends. At the outset, I really thanks the sponsor of this program, AstraZeneca, who has given me this opportunity to interact this scientific program. Everybody knows that lung cancer is one of the commonest disease seen in man, and one of the, despite of multimodality treatment, we have a mortality. And today we will update ourselves what we are having a treatment option in 2023. But before that, I just want to highlight the magnitude of this disease in United States and globally. Just see, lung cancer is the leading cause of a cancer death in the United States. And as per 2023 data, approximately 238,000 new cases diagnosed. And out of that, 127,000 patients died because of this disease. You will surprise, during the COVID pandemic, the diagnosis and treatment of lung cancer has been hampered. However, this has not been reflected in the 2023 data or estimated by the incidence and mortality because of this typical delay in collecting and reporting the data. Only 22.9% of all cancer patients are alive 5 years as per the United States data. More after diagnosis. This includes patients with non-small cell lung cancer as well as those who are having a small cell lung cancer from 2012 to 2018. The entire 5-year survival is increased in few years. You will surprise that adenocarcinoma of various biomarkers have a better survival as compared to the squamous cell carcinoma. You will surprise that the incidences are decreased in man in the tune of 2.6% and in women 1.1%. The important thing which I want to convey you that lung cancer presented like an tuberculosis. Most of the time we have a hemoptysis, cough, chest pain, fever. This mimic the tuberculosis, and that's why there is a delay in the diagnosis of lung cancer. And we basically have 2/3 patient presented to us in an advanced stage, or you can say metastatic CA lung. Today, we will discuss the overview of the lung cancer by our eminent speaker from Jammu, Dr. Nadeem Shaukat, one of my colleagues who is a medical oncologist there, followed by choice of essential biomarkers. I tell you, adenocarcinoma survival changes from 15% to 50% with biomarkers or targeted therapies in a present era. The Dr. Javed Muzammil, again my colleague and friend from Srinagar, will tell us about the choosing essential biomarker or NGS in early and late cancer. Followed by our third speaker, who is from Sora Srinagar Cancer Institute, Dr. Alfat. Basically, he will tell us about the practical approach in the clinical management of EGFR non-small cell lung cancer, followed by a panel discussion on a case base with multidisciplinary approach in this scientific program. I would like that my colleague, Dr. Nadeem Shaukat, will tell us about the overview of lung cancer, and I call Dr. Nadeem, who is a consultant medical oncologist at AOI Batra Hospital, Jammu. Dr. Nadeem Shaukat, please.
Thank you. Good evening. First of all, thanks to organizers, thanks to Sunil sir for allowing me to present here on this overview of lung cancer. So just I will share my screen. I hope my slides are visible.
Yes, Nadeem.
Yeah. So although it will be unjustified if I try to cover whole of a lung cancer in just half an hour presentation. But still, I will try to give just an overview. I mean, how the treatment has evolved, how there are changes have come up in the treatment of a lung cancer. So, starting with the Globocan 2020 data, as you can see from those two pie diagrams, the burden of lung cancer in India, as if we combine both of the sexes, as you can see, lung cancer comes at a number 4. While if we talk about only about males, it is the next most common after head and neck cancer. So we can say that it's the most common cancer among males in India. So as far as staging is concerned, I mean, you can see now AJCC 8th edition has come up since 2018, and there are some of the changes which has happened over a period of time since as compared to the 7th edition. As you can see, the T2, T3. I mean, the if the lesion was of size of more than 7 centimeter, it was being labeled as T3, while in AJCC 8th edition, it is being labeled as T4. And moreover, there was no entity of a 3C in this AJCC 7th edition, while in AJCC 8th edition, there is a 3C. So as far as investigative tools are concerned, I mean, for staging, although we do use bronchoscopy, but yes, all early stages like stage 1, 2, 3, we have to get the bronchoscopy, and then CT chest. Yes, although I mean, PET-CT has been widely used, and moreover, its availability has also increased over a period of time. So presently, most of the time we do prefer for a PET-CT, but then yes, there are limitations also. Then coming on to the E-bus, endoscopic ultrasound, yes, and then mediastinoscopy, and then MRI brain. Although MRI brain is recommended as per the NCCN guidelines, although in all stage 4 cancers we do ask for a MRI brain, but other than stage 4, we can ask for a like stage 2, 3, because we have to be very sure about asymptomatic brain mets. And as far as mediastinal evaluation is concerned, I mean, although the preferred tool will be those like non-invasive tools like EBUS or endoscopic ultrasound, but yes, at times, even if we get to see on a negative sampling or a negative reporting on this EBUS or endoscopic ultrasound, still we have to go for a mediastinoscope. So as I already told you, I mean, CT has got a limitations, but yes, if lymph node size is of more than 10 mm along short axis, it strongly predicts malignancy, and moreover, CT has got a limited role in as far as sensitivity concerned, just 55%, and moreover, it has got a low specificity of just 81%. So, although I mean, it can help us in selecting appropriate procedure for tissue sampling by providing the images, and then if we add just PET to the CT, it improves the overall sensitivity and specificity also. So sensitivity goes on to 80 to 90%, and the specificity goes to 85 to 95%. So, what are the risk factors where we can get to see a occult N2 disease? Yes, it's very important because when, although I mean, as Sir has already pointed out that in the era of COVID, we got to see so many lung cancers, at early stages because people do got screened by this HRCTs. So in that, keeping that into mind, I mean, yes, we are supposed to strongly look for this occult N2 disease. So where are the chances where we can get to see that we can get to see N2 disease? So N2 disease is it all depends upon the tumor size and moreover the location of the disease. And the third thing is the SUV. So looking at this tables, as you can see that as the size keeps on increasing, the probability of this occult N2 mets also gets on increasing. And moreover, it is the location. So all those disease patients who have got a central located tumors, there is a strong probability of a N2 disease as compared to the one where it's a periphery located tumors. And then coming on to the SUV, so those tumors who have got this SUV of more than or equal to 4, they have a strong probability of an N2 as compared to those who have got a less than 4 SUV. So we can say that cutoff of somewhere around this more than 4 and more than 4 or somewhere around 3, more than 3, and then size of the location of the tumor, that is those who are having central tumors, and then higher SUV, that is more than SUV of a 4. They have a strong probability of a this N2 disease. So coming on to the mediastinum staging, yes, for those early diseases, we have to screen the mediastinum. So mediastinum, how that is to be screened? So there less invasive approaches like endoscopic ultrasound or EBUS, and then invasive approaches in the form of mediastinoscopy. In that, we can use conventional this video as then VAMLA technique, then TAMLIZER transthoracic, and then video assisted thoracoscopy VATS technique. So as you can see, for mediastinal staging, as I already told you, less invasive EBUS and endoscopic ultrasound, these are the recommended techniques. So as you can see from this figure, it is well evident all those patients who have got a supraclavicular nodal disease, so it comes under N3. And then if clinical suspicion of an N2 involvement is high, even after a negative, I told that surgical staging with a mediastinoscopy is strongly recommended. So besides this, the other nodal stations uh, that can be seen, like this, if you talk about the hilar or interlobar nodes, they constitute N1 disease, while those who are having this upper mediastinal, I mean superior mediastinal nodes, and they constitute N2, and moreover aortopulmonary as well as inferior mediastinal or subcarinal nodes, they constitute N2. So even if somebody has got a, and all those if somebody has got a hilar node, but if it's ipsilateral, that constitutes N1. But if it's a contralateral, anything contralateral, any contralateral node, that constitutes N3 disease. So when is invasive mediastinal staging indicated? Yes, as I already pointed out, that those who have got a centrally located tumor, there's a high probability of a this nodal involvement N2 disease in, yes, those patients, and those who have got a tumor size of more than or equal to 3 centimeter, and then those patients who have got extensive infiltration of the mediastinum with no evidence of extrathoracic disease, where you are contemplating a local treatment, yes, you have to go for invasive mediastinal staging. And then if somebody has got a bulky nodes on this CT, that is good enough. I mean, don't need to confirm it with invasively. And yes, if there you get to see a discrete N2, and yes, you have to go for invasive mediastinal this workup in irrespective of the PET-CT result. And if somebody has got a normal mediastinum on CT but positive on PET, yes, go for mediastinal this staging. But if somebody has got a negative PET, no, it's not required. So with this, I mean, we can frame this algorithm as you can see that PET-CT, if it is PET-CT showing intrathoracic lung cancer with or without enlarged lymph nodes. So if you are getting mediastinal lymph node negative and there's a very low probability, and so straight away you can go for a surgery. But yes, clinically there are N1 or there is a clinically N0, but high probability in the form of like somebody has got a central location of a tumor or size is high. Yes, in that case you have to go for a mediastinal mediastinal evaluation. But somebody is already having this mediastinal lymph node positive on a PET-CT, then you have to look for a how big are the nodes. If they are bulky enough, so in that case no tissue confirmation is required. But if they are small, I mean, they are doubtful, yes, in that case, you have to go for a mediastinal imaging, mediastinal evaluation. So these are the lymph node stations which can be evaluated by different techniques. As you can see, I mean, all this TAMLA is able to screen almost all of the stations, but except for this 11R or 11L. So these are different. I mean, this techniques by which you can see the mediastinum. But if you look at the sensitivity pattern, I mean, highest sensitivity, as you can see, this EBUS plus endoscopic ultrasound, then VATS. So all those have got a very high sensitivity. But yes, if you just look at the CT only, but it has got a very poor sensitivity in the form of just 55%. So as we are, I mean, well aware how the lung cancer treatment has evolved over a period of time. Previously, it used to be the just single entity, and then came the histologic classification, and then here came the molecular pathologic classification. And now it has been practically classified even in terms of this mutational burden also. So now, I mean, previously we used to say that one shoe fits all approach. Now it's not like that. It's a sort of a tailored treatment. I mean, every person is having altogether a different disease, and moreover, we have also observed that it's not. I mean, every patient behaves very fatly. At times, we have seen stage 4 cancers, even those with the brain mets also, they have been surviving for a very long time. So as you can see from this diagram, how although trends in incidence and the mortality, although it has decreased over a period of time, but yes, the way incidence has come down, the mortality has reduced much better as compared to the incidence. So as you can see, lung cancer specific survival, it has improved from 26% among men that was diagnosed in 2001 to 35% in 2014. So we can say that it is all because of those treatment advances which has come up, and moreover, the era of a targeted therapies have come up. So as it is evident, I mean, just different time periods, how those different milestones and how those targeted treatments have come up for those lung cancer treatments. So, molecular profile, although I mean, whenever we get to see a non-small cell lung carcinoma, initially only as a part of our evaluation, we ask for a this molecular NGS based approach. We ask for those this molecular classification. We look for all those targets. So these are the this FDA approved. There are FDA approved therapies for all those targets like EGFR, ALK, ROS, BRAF, NTRK, MET, and RET. So, I mean, that era is not that far away then when we are going to see I mean, sort of a very complex, I mean, because the way never and never targets are coming up, I mean, it is really getting difficult and difficult. So there is an increased need for a molecular testing in a non-small cell lung carcinoma, and moreover, molecular testing should be a standard of care in a non-small cell lung carcinoma at evaluation at the beginning only. So, what are the current guidelines regarding the neoadjuvant and adjuvant therapy? It all depends upon the stage and the findings during surgery. As stage 1A, the recommendations are that they are to be just observed only, and there is no benefit of either you talk about neoadjuvant or adjuvant chemotherapy. Then, when you talk about stage 1B or 2A, again, uh, there is no proven benefit of a neoadjuvant therapy, but yes, you can. There's a multidisciplinary team involvement in the for the recommendation regarding the adjuvant treatment. And moreover, even if we talk about the adjuvant treatment, adjuvant chemotherapy, whatever you give, hardly the benefit maximum at max goes to somewhere around not more than 5%. And even if we talk about the stage 2B, N0 or N1 nodes, yes, adjuvant chemotherapy is very much recommended, and there is a no proven benefit of a neoadjuvant treatment. And then if you talk about the stage 3A or a 3B, that means those who have got an N1, N2 lymph nodes, you do can consider for a neoadjuvant chemotherapy or adjuvant chemotherapy, and moreover, you can even you have to consider those patients for this chemo radiation also. The preferred approach is to combine concurrent chemo radiation, but yes, if the patient is frail, and you can even consider for a sequential treatment also. But the sequence involves first chemotherapy and then radiotherapy. So as far as neoadjuvant or adjuvant approach is concerned, I mean, whom to select for a neoadjuvant, whom to select for adjuvant. I mean, the idea behind this is, I mean, it has not produced any survival difference whether you use a neoadjuvant or adjuvant approach. It is almost same. But the idea is, I mean, where you do expect that there can be a post-operative lot of a morbidity, and so which can delay your adjuvant treatment. In that case, it is better you consider for a neoadjuvant chemotherapy. So I already pointed out how this surgical staging influences the treatment and how we have to consider for. But all those patients who have got this positive margin, if there is a R1 resection, in that case, you do have to consider for a concurrent chemoradiation, irrespective of the pathologic this evaluation. So whatever initial treatment you do, you more than half of the patient they are going to recur. So that means around 50 to 60% are going to recur, and 40 to 50% are only going to live longer. So I mean, there is a good amount of unmet need. I mean, for all those patients. So latest ESMO guidelines, they do recommend that adjuvant chemo be considered in all those patients who have a resected stage 1B disease, and those who have got a primary tumor of a more than or 4 centimeter. So there is a clear-cut benefit, as you can see from this slide. So as far as this latest meta-analysis is concerned regarding this choice of a chemotherapy and the amount of benefit, as I already pointed out that yes, cisplatin vinorelbine has been well established and well proven regimen for adjuvant treatment of this lung cancer. So what they have found, a pooled analysis of a 5 trials, they looked all those regimens which contained cisplatin, and what they found that cisplatin was the most common regimen used, and it was shown to prolong overall survival with a hazard ratio of 0.89. But yes, absolute benefit at 3 years it was 3.9%, while at 5 years it was just 5.4%. So, just looking at this diagram, as you can see from the different studies have been taken out, and what they have looked for which one is, which approach is the better, neoadjuvant or adjuvant. But if you see almost all everywhere, I mean, whether you talk about the neoadjuvant or adjuvant, both have got almost similar benefits. But as I already pointed out, that it is only those patients who have got a who are where you are expecting that this post-operative morbidity will be a lot and there will be a delay in adjuvant treatment, you do can consider those patients for a neoadjuvant treatment. Yes, now the era has come up where target therapy is coming on into early stages. Early stages, I mean, previously we used to say that targeted therapy is meant for only advanced stages, those stage 4 cancers only. But now the time has come up where the targeted therapy is being explored even for early stages. So, to answer this, there was an Adoro trial in which they used the adjuvant osimertinib, and in resected EGFR mutated non-small cell lung cancers, what they found that there was 80% reduction in the risk of a disease recurrence or a death with osimertinib. So osimertinib here, it was a phase 3 trial, and moreover, it was compared with the placebo. So with introduction of osimertinib, DFS improves from 44% to 90% in those patients at 2 years who took this osimertinib. So again, besides osimertinib, there is a data for atezolizumab also. But so atezolizumab is to be used in all those patients who have got a PDL1 of more than 1%. And what it has been shown that it 3 years, so there is a difference of around 12% in the DFS. So as far as this immunotherapy is concerned, is immunotherapy, yes, it has been tried in a neoadjuvant setting also. It has been mentioned in the NCCN also. So what they have seen that neoadjuvant nivolumab plus chemo has been just whatever different regimens were taken out. So what they have clearly shown that there is the overall survival improvement, and moreover, TAF-CR also improved. I mean, as compared to the immuno plus chemo, it went to up to even 25%, while with chemo it was just 2%. So with this, I mean, background, and moreover, there were clear cut what has been mentioned in the NCCN regarding that checkmate trial. What they have mentioned that yes, those that immunotherapy it's not needed to be used in an adjuvant setting. It is to be used just in a neoadjuvant setting. So in a neoadjuvant, we do can consider for a nivolumab plus chemotherapy. So besides chemotherapy and immunotherapy, yes, lung cancer radiation has also improved remarkably in 2022. So IMRT has come up, which has remarkably improved survival for those patients who have got a stage 3 non-small cell lung cancer and those who couldn't even get operated. So the reason behind that improving outcome was that because of the reduced dose to heart with low rates of greater than equal to grade 3 pneumonitis. And moreover, technique has also improved as compared to previously. It was just 3D CRT. Now IMRT has come up. And so as you can see, as far as radiotherapy dose is concerned, I mean, increasing the radiotherapy dose beyond 60 days, it has not made a remarkable difference in the 5-year OS. Rather, it has 5-year OS has decreased by increasing the dose beyond 60 grade. So even those patients who have got a stage 3 non-small cell lung cancer who couldn't get operated, who received concurrent chemo radiation, yes, post concurrent chemo radiation, there is a data for a usage of a immunotherapy in the form of durvalumab. Yes, there is a Pacific trial, and moreover, it's a phase 3 trial. So as you can see, this 5-year survival difference is around 10%. So durvalumab demonstrated that at 5 years, the OS was around 43% in comparison to the historical overall survival. Unresectable stage in non-small cell lung carcinoma at 5 years was just 25%. So emerging treatment paradigms include in the form of a targeted therapy as well as immunotherapy. So as far as stage 4 non-small cell lung cancers, we do screen them at the beginning for this any mutation by doing NGS. And yes, as I already just pointed out, there's how osimertinib has added on to the survival in the adjuvant setting. And yes, the data was earlier of in stage 4. in stage 4, it has made a remarkable difference as compared even to the already established first generation TKIs. And then if you talk about the ALK positive non-small cell lung carcinoma, yes, we have, I mean, many of us would have themselves experienced that those patients have easily survived for next say around 4 years, 5 years. And with chemotherapy, the median DFS was just 5 to 7 months. So besides this, there were other emerging molecular targets in the form of MET exon 14 for this crizotinib has come up, and then RET rearrangement, which is seen in just 1 to 2%. But yes, the targets include the drugs which can be used for the RET rearrangement include cabozantinib, vandetanib, and then anti-RK rearrangements. Yes, you can use larotrectinib as well as entrectinib. And then for all those HER2 mutations, although its the incidence is quite low, it is just 2 to 4%. You can use as adotrastuzumab and Temsi. So newer target agents are being identified. This will also help in improvement of the survival in those subset of patients. So yes, you can see here the all those targets which I already pointed out, like EGFR as well as ALK, they have made a remarkable difference as compared to the conventional chemotherapy. Then coming on to the immunotherapy, yes, in a stage 4 cancer, how, as you can see, if we start with from the 2015, the recommendations were to be used in a second line setting. And then there came in 2016, again, there were added other immunotherapeutic agents. But then after that, after 2016, those immunotherapy came in from second line to the first line. So again, if you talk about as compared to the conventional chemotherapy, yes, there has been a remarkable difference when you talk about the PFS as well as the OS also. So we can say that, like we take an example of a keynote 024, it has clearly shown that pembrolizumab has improved the survival remarkably as compared to the conventional chemotherapy in those patients who have got a tumor proportion score of more than or equal to 50%. So now the checkpoint inhibition is moving to the early stages, as I already pointed out, one of the trials in which nivolumab was used in a neoadjuvant setting. So besides this, the newer agents that can come up include antibody drug conjugates. So that is already has been approved, that therapy in the breast cancer, and it's coming up into the non-small cell lung cancer. As you can see, antibodies are being just combined to this payload, and then which disintegrates inside the cell. So besides that, now the CAR cell era is coming up, and the CAR cell for the timing, although I mean it is well established for those leukemias as well as lymphomas and myelomas. But yes, that day is not far away when it will be evaluated for this lung cancer also. So the key takeaway is that management landscape is fast changing, and moreover, newer therapies have got a huge potential to improve survival, especially when detected in early stages. And OS has improved remarkably across various subtypes. And yes, as Dr. Sunil sir has already pointed out, that it has become more of a tuberculosis. I mean, the patient keeps on taking medicine for years altogether. And moreover, the ease of those oral pills or infusions has, in case of a targeted drugs, is definitely an added advantage. And moreover, those pulmonologists who they play a huge role in the early diagnosis, because it is them who get to see the patient in those early stages. So it is very important that we have to involve those pulmonologists in our tumor boards. Thank you.
Thank you, Dr. Nadeem, for such an excellent overview. I would like to call the second speaker, who will tell us about basically the important aspect of the recent treatment options, choosing essential biomarker on NGS in early and late stage of non-small cell lung cancer. And for that, I would like to call Dr. Javed Muzammil, medical oncologist at Medicare Super Specialty Hospital, Srinagar. Dr. Javed Muzammil, sir.
Thank you, sir, for inviting me. Thank you, organizers. Good evening, everybody. Please give me this rights for the screen sharing. Are my slides visible?
Yes.
Okay, thank you. Thank you very much. My friend has already talked about the overview of the lung cancer. He has exhausted everything. He has told everything. So my job is to tell you about the how to test these biomarkers which we are using currently. So Dr. Nadeem has already discussed about Globocon 2020, so I don't want to discuss that. So lung cancer is still an important problem. And now we can see here on the point of view of the these driver mutations, our 50% of the patients, don't have these driver mutations. So that's the problem, that 50% of our patients have not any oncogenic drivers, so they will be treated with the chemotherapy. The rest of the 50% of the patients will have some driver mutation, which has been approved by the FDA either in first line, second line, or some are in the clinical trials. So the most commonly that we use are the EGFRs for the drugs for the EGFR mutation, and followed by the L mutations. And we have second line that this RAS mutations where the sotorasib adagrasib has been approved. So coming to the survival based on those driver mutation drugs, drug mutations versus chemotherapy, as Dr. Nadeem pointed out, that we do see our patients at 4 years, 5 years living in stage 4 disease with these druggable mutation and give proper drugs. Otherwise, what has been seen, the overall survival with chemotherapy has been less than 1 year. So there came the guidelines for the biomarker assessment for small cell lung cancer. So if we talk of the International Association of Study of Lung Cancer (CAP) guidelines, they included 4 markers initially in the 2018 for checking patients who like EGFR, LROS, and RAS mutation. Then subsequently, ESMO, they included more markers into 20, and ESCO also, they included more markers except the RAS mutation. NCCN advocate that you have to check all markers, whatever the investigation you do. Basically, we are just talking about the NGS, that in multi-gene panel, you assess all those markers. So the methods of assessing these markers, driver mutations in non-small cell lung cancer, so multiple testing facilities now available. You have DNA-based NGS, RNA-based, you have DR, you have FISH. I see that was the first thing that was introduced for most of the markers, but all the markers cannot be checked by the ISC and the FISH. So I just for the fusions and
Dr. Javed.
yeah, I had lost the connection.
Oh, yes, Dr. Javed.
So I think I was here. So, sir, am I audible? Am I
Dr.
audible?
Javed, yes, Dr. Javed, you are audible.
Okay, I will close my video because the network is not stable. So we have all those investigations now available as DNA sequencing, NGS, NGS, the best NGS that detects most of the fusion abnormalities, the RNA NGS. So these biomarkers as the treatment armamentarium in the non-small cell lung cancers has evolved over a period of time. Same way it has evolved, this biomarker testing has also evolved over a period of time. Here on, we use tissue biopsy either by resection, by true cut biopsy, by CT guided biopsies, or by bronchoscopy biopsies. We used to get this biopsy as a fresh or the paraffin laden tissue specimens, you were sending them to the lab for histopathological examination, and the pathologist was giving you the details about the non-small cell lung cancer as squamous, non-squamous, or large cell type, or neuroendocrine type, whatever it was. And from the cytology also, they were making the cell blocks and giving the same results, and then further assessing and extracting the DNA, RNA, and they were looking for the driver mutations. Nowadays, we have liquid biopsies as well, where you have to just take liquid biopsy from the blood or from the body fluids and send this for ISC and send them for these biomarker tests, whether you do NGS, with this DNA-based NGS or RNA-based NGS. So biopsy, that is still the cornerstone for diagnosis. That tissue biopsy, it will help you to tell you about which small cell lung cancer you are dealing. So the pathologists are still important, other than that of the molecular, these biologists, but pathologists are still in histological subtype. So what about the further investigations that is based on which type of the non-small cell lung cancer you are dealing? Yes, for PD-L1 expression, you have to do it for all non-small cell lung cancers, but rest lies the for non-squamous adenocarcinoma, that you have to broad-based NGS and you have to do all the GFR, ELK, ROS, RAF, and your RET, MET, and rest. Not this very less, we are less common mutations. You also do that. But for scammers, where else you will do these investigations? These are those patients who are just female, younger patients, non-smokers, and the mixed histopathology. There also we can do same kind of the investigations. So now CNA has come up in a big way that it's not only that it will diagnose the thing and it will allow you to make the treatment selection based upon the type of the driver mutation you see, and it will also help us in the prognosis and response to the treatment progression in those patients where you have already resected or where there has been disease earlier and you follow those the stage 4. So ctDNA will help you to see the next line of the treatment as well. Another important advantage of the ctDNA is that it will have the heterogeneity of the tumor. In one area tumor, if you biopsy, you will see EGFR mutated. In other area, maybe there is some co-mutation that is present. So you may have for the approach than single driver mutation approach. So it is the privilege by the ctDNA. So this one of the study, that is TRACER-X study that done in early stage non-small cell lung cancer who were resected, and they were followed phagetically, and it has been seen that those patients who had MRD positive, around 13 out of 14 times they had MRD positive and they progressed. That means they relapsed and had an MRD positive. So it had a 93%. This information EU. Once MRD is positive, that out of 93% of the times this patient is going to relapse. And similarly, if a patient has MRD negative, in that 90% of the times that this patient is not going to relapse. So basically, high sensitivity and high specificity of the test that liquid biopsies are going to come with us these days.
Dr. Javed. Dr. Javed. Dr. Javed.
It's very unstable. Yeah. I'm hearing, sir. I'm hearing, sir.
Okay.
So we have advantages and disadvantages of these assays. and that we can see that tumor tissue is very difficult to get, but it is very easy to have that. That is for liquid biopsy. You can repeat the sample. You can repeat the sample. You can follow the patient for the another line of the treatment. So repeating sample is very easy for the liquid biopsy. And again, for this tissue biopsy, it's very difficult. And if a patient progress, it is very difficult to get for the biopsy and to take the consent from the patient. But there are some inherent advantages for liquid biopsy, inherent advantages for the tumor biopsy as well. We don't have yet that much of evidence of clinical utility for the liquid biopsy and the tissue biopsy. So that was the earlier era of that single gene reflex testing. So we used to have EGFR positive on PCR. Then we started the treatment on patient on these EGFR based TKIs. Then we ignore the rest of the these investigations. If we go for the single gene testing, but what has been seen in those also, just example that if a patient has the DEL19, we know that the treatment, once you start treatment there, at least progression-free survival in the stage 4 will be at least 4 to 9 months, as from the studies are concerned. But you see in your clinical practice that some of the patients are relapsing, progressing very fast within 6 months. So that means you are missing something. There is some co-mutation associated with it, which you have not seen if you do single gene testing. So that's why the next generation has now, it will tell you the information in one go at the beginning of the treatment, and it will tell you about the prognosis, and it will tell you about the selecting the next line of treatment. So that is the advantage of the next generation sequencing. We were earlier saying that next generation sequencing has a turnover time very long, but single gene testing turnover time is around 4 to 5 days. But overall, if we talk about the single gene testing, doing one after another, like EGFR followed by ALK, followed by another, by that turnover time will be more longer than that of the NGS, and the cost effectiveness will be better for the NGS than single gene testing, because you have to add every time 3,000 to 4,000 for single gene testing. So and for the NGS, it detects a broad range of the molecular alterations in just one simple sample, in single sample, and it will identify newer markers that could offer additional treatment options for the patient. But the problem is that it is highly complex. It needs experienced people, and the advancement in the field of NGS is evolving rapidly. So patients and clinical community must receive sufficient education in this area. So these are the techniques where molecular and landscape in non-small cell is changing, that we have single gene assays, Sanger sequencing, and many things, PCR, single base extensions. But we are seeing now next generation sequencing, where we can do all the markers, all the molecular markers in one go. So what about the EGFR mutations? How can we detect, and with what investigation we can detect? We can detect it from the paraffin laden these blocks, or fresh frozen samples which are fixed in alcohol, formalin. You can do by PCR based assays. And it has been seen whether you do primary biopsy or you do on the metastatic disease, where, for example, neck node versus the lesion in the lung, it has not shown much discordance. So they were almost concordant, whether you will do from the primary side or the distant side. So as Dr. Nadeem also said, that nowadays we have to do EGFR testing surgical specimens where the patient has been operated for early stage non-small cell lung cancer, where we have a data of the ADAURA trial. So EGFR testing is to be done in them also. Now, what test you will use for the EGFR testing? Is it NGS or is it PCR? What are the advantages of NGS or PCR in EGFR testing? And you are seeing that we have some these rare mutations in the EGFR that are exon 20 insertions. Around 50% of our exon 20 insertion mutations are not picked up by PCR. So you are going to miss them. So for those, this NGS is the better technique that it will pick up those insertion mutations as well. So that's the advantage of NGS in picking up the EGFR mutations. Then coming to the ALK rearrangement fusions, we know that we are being using this ISC, which is very less expensive and turnover time is very short. So it has a high sensitivity and specificity, but most of the times we reflexively use fish to see its authenticity. Same is the case with the ROS. If we have a ROS mutation, we have to check the ROS mutation. So again, ISC, if it is positive, you have to reflexively check it with the fish. Or if you've done fish for the ROS first, then you have to reconfirm by second method, that is ISC. But if we do NGS at the beginning, there is no need to confirm it with any other investigation. Same is the RAS mutations that we see. It is seen in 30% of the lung adenocarcinoma, and the druggable mutations in RAS are around 13%. G12C, where the sotorasib adagrasib has been approved for clinical use. And again, it is the multi-gene NGS panel where we can see, we can pick up those mutations. Same is the case with the BRAF mutation. Here we have more than 50% of the times we will be getting V600E mutation in BRAF, and this type of mutation is seen in 1 to 5% of patients of non-small cell lung cancer, preferably adenocarcinoma. So again, the NGS is generally used for multi-gene testing, which will pick up this mutation. Then the same with the MET mutations, MET exon 14 skipping mutation. Again, NGS is the preferred method in detecting, but more increased sensitivity we can detect with RNA NGS than DNA NGS. Problem with the RNA NGS is that the RNA gets degraded very fast in these blocks. So that's the only problem limitation, because most of the times the lab will tell you that RNA was not there. So we have done on the DNA-based NGS, DNA material. So methods for the MET14 mutation, picking that you cannot pick it fish. So the best method is NGS, and the method are more sensitive than DNA NGS. Then comes the RET mutations. RET mutations that again around 1 to 2% of the patients non-squamous non-small cell lung cancer, you will pick up the RET mutation. I think in my this career so far, I could see only one RET mutation in non-small cell lung cancer. Very rare. So again, it was picked up by the DNA-based NGS, which was a broad-based NGS at the beginning of the treatment of the patient. So the majority of the RET mutations, which can be picked up with DNA NGS, but as I said in my previous slide also, that it is the RNA-based NGS that has more sensitivity than DNA-based NGS. Then anti-RK fusions, which are more commonly seen in sarcomas and more commonly seen in metastatic colorectal cancer. The anti-RK fusions, the RNA-based NGS is most sensitive than DNA-based NGS. So reflexly, you will test NGS versus ISC, but it's the reasonable that you should consider multi-gene NGS and so again, the advantages will be potential for multiplex testing for the NGS because you will need less tissue and it won't be depleted once you do multi-gene testing, and slightly longer wait and the cost, but the labs are decreasing the cost for all those investigations nowadays. Then HER2 mutation, very uncommon in lung, but still 3 to 5% of patients can have. in adenocarcinoma. And if this mutation is present, it is the prognosis of the patient is very dismal. And this mutation, again, you will be picked by the NGS, but we have the general tests that are available as we detect them in the breast cancer by ISC, by this fish testing. You can use those tests as well for this HER2 testing in non-small cell lung cancer. So that is this is the 2022 treatment paradigm for molecular biomarker positive advanced and non-small cell lung cancer. As Dr. Nadeem has already discussed, the molecules that we have for each and every this biomarker driven lung cancer, that you have to have a proper technique. Which technique you are using for detecting these mutations, then you can molecularly target them in your treatment guidelines. So coming to the PD-L1 overexpression in non-small cell lung cancer, as this test you have to do in both squamous and the non-squamous. Now we have multiple these platforms that are available. The two platforms which use a different antibody clone like DECO and Ventana. So once you are selecting a particular immunotherapy, immune checkpoint inhibitor, you have to select the proper cell clone as well, proper platform as well. So for the pembrolizumab, if you have to use that, so you have to use a DACO platform of cell clone of 22C3. If you have to use durvalumab, so you have to use Ventana platform with cell clone of SP263. And for atezolizumab, you have to use cell clone of SP142 Ventana platform. So keeping these things in mind, we have to order this cell clone, particular PD-L1 antibody clone for particular antibody. So again, are there other biomarkers for the immunotherapy? It's a controversial topic. You can have that is tumor, this mutational burden, as Dr. Nadeem said, that's one of the biomarker you can use for selecting the PD or PD-L1 antibody treatment. But MSI, MMR testing that has not have no relevance in lung cancer, and there are some other markers as well. So for us, this time at present era, we have PD-L1 expressions that are used for predicting that you will give immunotherapy or not. So concluding my talk of these biomarker testing in non-small cell lung cancer, it's evolved and has evolved from single gene, now multiple gene testing, and you need to have a multidisciplinary meeting that helps in better understanding the sample and what test you will order. At least you have to have an adequate tumor content in that block, and turnover time for these NGS-based tests are around now 2 weeks, and you have to use a proper platform such as NGS that can be used to screen several genes at one time. So this we have this. I think we have discussed about EGFR, which test we use, that PCR or NGS. So overall, it's the multiple gene you have to test. So you have to ask for the NGS-based, that two RNA-based NGS. Thank you very much.
Thank you, Dr. Javed Muzabil, for such an excellent talk on a biomarker. Now I will move to the third speaker who will tell us about a practical approach in clinical management of EGFR non-small cell lung cancer. And for that, I would like to call Dr. Alfat Ara, Assistant Professor, Department of Medical Oncology, Scheme Sura, Srinagar. Dr. Alfat Ara, please, for his talk.
Good evening, sir, and a very good evening to my all dear colleagues, students, and all my dear friends. Can you allow me to share my screen?
Oh, yes.
I'm not able to share the screen. Can you start the slideshow from your side?
Yeah, 1 second, ma'am.
Okay. Good evening, everybody. I'm going to actually discuss a very important topic, that is a practical approach we should follow in the clinical management of EGFR lung cancer. As we know, EGFR mutated lung cancer is the most common driver mutation positive lung cancer. So we'll be concentrating here only on the management of EGFR positive lung cancer patients, how to do it clinically. Next slide, please. As my dear colleagues have previously discussed it in length, that lung cancer is the most common cancer. It accounts 11.6% of all the newly diagnosed cancers, but the burden of mortality from this cancer is more as compared to the newly detected cases. That is 18.4%. That is, mortality is still high despite various advancements in lung cancer treatment. Next slide, please. In both sexes, in both sexes, the most commonly diagnosed cancer is the lung cancer, and as I previously said, that it is the leading cause of death in the patients with malignancy. Next slide, please. Now, EGFR mutation positive non-small cell cancer. We know that EGFR mutation positivity rates are very high in Asian population as compared to non-Asian population. It's approximately 40% in Asian patients and 20% in non-Asian. But if we see the data in the Indian population, there are certain states which have extrapolated their own data, and even in Asian certain regions, the EGFR mutation positivity is very high. It goes around 60% also. So the incidence of EGFR mutation positive mutation, if you consider overall in Indian patient population, it is 20 to 23%. And we know that this EGFR mutation basically affects the kinase domain of the EGFR receptor. Next slide. Using the best drug first will maximize the benefit to all EGFR mutation patients. Basically, the crux in this slide is that it is best in all the malignancies to hit hard at the first. This means that at the first time, most of the patients, even if they are in stage 4 patients, which you are going to treat, will be in the best performance status. And if you strike the heart at the first diagnosis, because subsequent lines of treatment, we find that as the patient becomes resistant to first line treatment, most of the patients have a very poor performance status, and then because of other reasons also, they're not fit for subsequent lines of therapy. So it would be best that once the patient is diagnosed, we should hit with a drug which has the maximum benefit in that situation. Next slide, please. Now, as far as EGFR mutation positive lung cancer patients are concerned, we have 3 generations of EGFR TKIs which are available with us. That is first generation, second generation, and third generation TKIs. Next slide. Now, third generation TKI osimertinib as first line. We know that in category 1 recommendations, if we go in NCCN guidelines, osimertinib is a category 1 recommendation. In fact, the other TKIs are also like first generation, second generation. They've also clubbed them as for category 1. But the preferable drug is this third generation drug, osimertinib, which we subsequently will discuss the benefits in terms of PFS, OS, response, and drug side effect profile. Why this drug we are preferring as a first line drug now? Now, this is what I previously told you, that NCCN recommendation, all the drugs like alotinib, afatinib, geftinib, dacormitinib, they're all category 1 recommendations for EGFR mutant positive these patients. But if you consider osimertinib is the category 1 in the in brackets, it's mentioned preferred. Preferred, why? Because of this drug scores as compared to first and second generation TKI in many aspects, which we will subsequently discuss. Next slide, please. Now, osimertinib, why this drug? This is a third generation compound, but it basically binds to the ATP binding site of the kinase domain covalently. So it is an irreversible binding. And why the side effect profile is different as compared to the first and second generation TKI, even if there also, because it is highly specific for EGFR part. It does not, its off-target effects, side effects are very less. Like it does not affect the wild type EGFR receptor. It does not bind to that receptor. So its off-target side effects are very less. This is because of its mechanism of action. And its sensitivity to bind to this, tyrosine kinase domain ATP binding site is very high. It has a high affinity, and therefore efficacy is also very high. Next slide, please. This is how we know that this is the same what I have discussed, that this drug osimertinib, it does not bind to the wild type EGFR. So its efficacy is high because it is covalently binding to the ATP binding site. It is an irreversible binding, and plus its role in EGFR T790 mutation upfront, because in these cases, we know that first and second generation TKIs won't work. And then wild type EGFR, it does not bind to this drug. So its off target effects and the side effect profile is completely different from first generation and second generation TKI, which scores this drug over the other two generation TKIs in terms of tolerability as well as efficacy. We know that FLORA study, this study was actually done in patients who had, initially we know that the data for osimertinib arised in patients with stage 4 metastatic. Now we have in adjuvant setting also ADAURA, though we are here discussing the patients in stage 4, that means metastatic patients. This trial actually included all the patients which were more than 18 years, performance status was very good, like 0 or 1, and exon 19 and L858 mutation, which had not received any prior systemic anti-cancer treatment, and they had stable CNS mets. They were also allowed. See, in most of the trials in previous with first and second generation TKI, like in decomitinib, they usually excluded those patients who were having CNS mets. This is also one of the advantages of osimertinib, which we will subsequently discuss, that it is only third generation TKI. It is this TKI, this third generation TKI has a property of having very high CNS response rate, very high CNS penetration as well. Next slide. Now, osimertinib in this trial, FLORA trial, it has demonstrated it is the one TKI which has really scored over first and second generation TKI in terms of PFS benefit. The PFS with this drug is, significantly longer as compared to the PFS with first and second generation TKI. It is almost 18.9 months. And as far as osimertinib is concerned, we have to agree with this fact that this is one of the TKI whose PFS benefit subsequently translated into a significantly overall survival benefit for the patients who had EGFR mutation positive lung cancer. Here, I would like to mention one thing, that when we do EGFR mutation panel, 85 to 90% mutations will come in L858R mutation positive, 21, that means exon 21, 40 to 45%, and exon 19. These are the most common. Then we have the uncommon mutations like G719X, E709X, and exon 19 insertion and missense mutation, and S7861. These are comprising approximately 10 to 15% of the uncommon mutations. Now it will be arising in the minds of our dear students and colleagues that when we encounter these mutations, osimertinib in most of the situations in uncommon mutations EGFR, which will comprise a very small group, is not the first line of drug. In these mutations, we have to consider afatinib. Afatinib is the best drug when you are finding uncommon mutations. Yes, there are certain uncommon mutations like exon 18, G719X, and E709X, and exon 19 insertion mutation, where osimertinib may have, there is some data that osimertinib does have some activity, but in all these, uncommon mutations, it is the afatinib which scores over osimertinib. So another point of concern is exon 20 insertion mutation. We know that in this mutation subset, the TKIs don't work. Either you give chemotherapy, or now we have drugs available also. But I would like to mention here that in some trials, osimertinib has been found to be effective in this setting also, but the backlog is that in exon 20 insertion mutation, the drug concentration of osimertinib required is appreciably very high, almost 10-fold higher. So that is why in most of the trials, this osimertinib was not later on tried. You had to give a dose more than 80 milligram, and then naturally the side effect profile worsens, and tolerability of the patient was not found to be good. Next slide, please. See, as far as all the patient subgroup which were considered in this trial, irrespective of sex, age, race, smoking history, CNS met, or performance status, or this circulating tumor DNA levels, all the parameters you will see that irrespective of underlying all these factors, osimertinib has been found to have a significant hazard ratio if you compare with other EGFR TKIs. So irrespective of the underlying patient profile or patient subgroup profile, osimertinib scores over the first and second generation TKI. Next slide, please. Now we know that, as I told you previously, initially the trial was actually tailored to show the PFS benefit in metastatic or stage 4 CA lung, but then subsequently this was the drug which showed a significant OS benefit. The OS overall survival benefit, median overall survival with this drug has been 38.6 months, which is something really to achieve in a stage 4 CA lung with the driver mutation. See, this kind of OS benefit and PFS benefit has not been ever found previously with other drugs. So this thing has now translated into OS benefit, which is, again, a very important indication for clinicians to strike on for this drug. Most of the trials initially will actually start or being planned with the PFS benefit, because we know that OS, many other confounding factors come up. But in this trial, we have achieved an OS benefit also. And many patients, see, because of the good tolerability of the drug, at 2 and 3 years, if you consider, more patients were able to continue this drug. And there are certain drugs which find PFS benefit, but they are not, their tolerability profile is not good. So most of the patients drop out in the trials later on. So because of that thing also, the clinicians are worried whether we should use this drug or not. But as far as osimertinib is concerned, we know it scores over other drugs because its tolerability profile, as I said, off-target side effect profile is very, less as far as other generation TKIs. In fact, we can say that wild type EGFR, it does not act at all. Next slide, please. 28%, this is what I was considering this EGFR TKI mutation positive patients. We know that the dropout rate subsequently at 1, 2, and 3 years, if you find in the previous trials, especially if you compare dacomitinib, which has, comparable, there's a narrow gap as far as 14 months PFS and 18 months PFS, we can consider it is high as compared to other TKIs. And OS benefit also. But if you consider the dacomitinib versus osimertinib, this is the biggest point, that dropout rate with dacomitinib has been very high because its tolerability profile is one of the worst among all the TKIs. So, but this is not with the osimertinib. Osimertinib scores both in efficacy as well as in tolerability. So we can find that 30% of patients at 3 years in this trial were still ongoing on osimertinib. Next slide, please. Again, the benefit in terms of time to first subsequent treatment. Again, we know that osimertinib scores over that. Osimertinib median, duration to start this next line, 25.5 months, as compared to other TKIs, we know it's 13 months only. So there is a significant and a marginal difference as far as time to subsequent treatment is also concerned, or that. Next slide, please. Osimertinib provided unprecedented improvement in PFS in the FLORA trial. As we can see here, they have compared the PFS with all the first and second generation, and then with osimertinib, we find the highest PFS benefit with osimertinib, 18.9 months, followed by dacomitinib, 14.7 months, and alartinib, 13 months, and with afatinib and gefitinib, 11 months and 9.5 months, respectively. Next slide, please. Now we know that if you compare the efficacy of osimertinib, we have already discussed this. If you consider all the parameters of the patient subgroup, like age, smoking history, age screening, then PFS, then CNS met, everything, ctDNA, it is the one TKI which has scored in all the patient subpopulation subgroups. That means we have a strong evidence of starting osimertinib as a frontline, TKI in all the patients who come out to be EGFR mutation positive. Next slide, please. Now we know that Osimertinib, it has basically a PFS benefit that has been clearly maintained, and it has translated into a significant overall survival benefit. This is consistent with PFS data in which all the subgroups favored osimertinib. This we have already discussed. You consider any patient subpopulation group, osimertinib really has fared well. Next slide, please. Now, first generation EGFR TKI, initially we had started all the EGFR mutation positive patients with trials like geftinib and alotinib. Next slide, please. Now, EGFR mutation advanced non-small cell cancer patients, different trials have been conducted in our Indian, different parts of our India, and all the trials actually have shown that it fares as well in our Indian population as it does in the rest part of the world. So, as Indian clinicians should be now very confident that this drug is as effective, because we know that the basic genomic and pharmacogenomics of the drug actually varies in different races and different subpopulations. So, in all Indian clinicians should now be very confident in using this drug, because it is as effective as in other populations, because first the trials come from the Western data, and then we usually use the drug here also. But then extrapolation of Western data to the Indian subpopulation is not that fair unless and until we have our own data to produce that it is really working in our population. So we are confident that, this way also, because it has really worked nicely in our patient population. Next slide, please. Now, second generation TKI and then osimertinib. See, actually, there has been always a concern that we reserve osimertinib for subsequent, subsequent treatment of EGFR mutation positive. Start with, some people say even start with first generation or second generation and reserve this drug later on. But there are caveats actually, though there is a one trial, Geotac, kindly next slide, which has shown that initially, if you start with a second generation, that is afatinib, and then subsequently you go to osimertinib, the overall survival benefit has been, significant, like 41 months. But actually, if you consider the overall trial design, next slide, please, there are caveats in this trial, because actually, they in this, like in Archer trial, they actually had enrolled 452 patients across 7 countries, and Flora trial had included 556 patients. And actually, if you concentrate on the exclusion criteria of Archer trial, they had excluded all the patients who had brain and leptomeningeal mets and history of or currently suspected diffuse non-infectious pneumonitis or interstitial lung disease. That is fair, but from a point of view, the patients with CNS mets were included in Flora trial. So patients were assessed at the investigator's discretion for CNS metastasis if they had a history of or suspected CNS mets. This is the biggest difference. See, as far as EGFR mutation positive patients are concerned, upfront even they have 33% patients which will present with brain mets. And subsequently, we know brain is a sanctuary site, and this is one of the frequent site to get relapse also. So most of the earlier trials with earlier generation TKIs, they have excluded the patients with brain mets and leptomeningeal mets. But the Flora trial has included these patients with CNS mets as well. Next slide, please. So if you consider the PFS benefit in the Archer trial, you can see that the PFS curves has started separating after 6 months. Whereas in the Flora trial, right from the beginning, the 2 PFS curves are separating. So this is again, one of the biggest differences between the second generation TKIs and this our current osimertinib, what we are using as a third generation TKI, that this scores over other drugs, because you will find a PFS benefit in the patients right from the beginning. You can see the curves have started separating as early as possible, and then this PFS benefit has been maintained beyond 24 months. That is why this is translated into a significant survival benefit as well. So this is for the understanding of our students as well. All the colleagues, my dear colleagues, are much better aware than me about this fact that dacometinib, though scores over other in this TKS, as far as PFS benefit is concerned, or OS overall, it is 31 months with this dacometinib overall median overall survival, but with osimertinib it is about 38.6 months. But you should see the PFS benefit curves are separating in dacometinib after 6 months. Next slide, please. So Archer said OS not statistically significant since the formal comparison of ORR, that is overall response rate, was not statistically significant based on the study's hierarchical testing rules. Actually, in this trial of Archer, they had done this multi endpoints they had taken, and then they have at the last assessed many points, and then there was a confusion. So Dacometinib, you cannot approve that overall survival is really so high as compared to other TKIs. Next slide, please. So actually, this is what I was telling. The trial had a hierarchically stratified statistical design, which means they had taken actually multiple endpoints. And what they had done once, this hierarchical statistical design means you take a multiple endpoints. First, they should pass on one phase, then second phase, then third phase. The endpoints are statistically spread, and at the last, you have a lot of confusion. So because of this caveat, you cannot actually extrapolate the Archer 105 trial design in your clinical practice with, really authenticity. Next slide, please. So this is a comparison of Archer trial and our Flora trial. Flora trial, it was a double-blinded study, whereas Dacometinib's trial, this Archer trial, was an open-label study, and the patients with history of brain leptomeningeal mets were excluded in Archer, but in osimertinib, they were included. Median PFS, as we previously discussed, 14 months in Dacometinib, and osimertinib, 18.9 months. And we know the curves have started early, separating in Archer trial late, that means 6 months, but in osimertinib earliest. And we have seen that as far as overall response rate, if you compare, it is 75%, and then duration of response 14 months with Archer trial. But if you consider osimertinib Flora trial, the median duration of response is 17 months, and the median OS 34 months and 38.6 months. You may say that it is very close, that OS is there, but I have previously mentioned that Dacometinib, adverse event profile is exceptionally bad among all these EGFR TKIs. Its dose reduction is required in 66% patients, whereas in osimertinib only 3% patients require dose reduction. And the mortality with this drug in osimertinib is only 2%, but with Dacometinib it is 10%. And the serious adverse events with this Dacometinib overall are 27%, and the osimertinib is 4%. So if you consider the tolerability of the drug, there is a significant difference between Dacometinib and osimertinib. Next slide, please. So this is again the Lux Lung 7 and Archer 1050 trial. We can see that afatinib failed to improve the OS versus Geftinib in Lux Lung 7 trial. There was some, PS benefit, but ultimately, if you consider the OS benefit, it was not statistically significant. And in Archer 1050 trial, there is a hierarchical gatekeeping procedure. It was used for hypothesis testing, which I told you what it means. So even if you have PFS and OS benefit, you are not, sure about this trial. Next slide, please. Now, this we know that the separation of curves, Lux Lung 7, then you compare Archer, then you compare the Flora. The curves are separating earliest in the osimertinib at 6 months in Archer, and then you see the curves going very close in afatinib versus Geftinib in Lux Lung 7. Next slide, please. So also now we have to consider brain mets, which is an important situation as far as our patient of EGFR mutation positive patient. As I said, 33% patients will present with CNS mets. And the CNS response rates with other EGFR TK, as I told you, they don't penetrate the blood-brain barrier at sufficient concentrations to have, CNS response rates significant. Next slide, please. See, osimertinib is an ideal treatment for all those patients which are EGFR mutation positive and who present with CNS mets. The actual consensus is that the osimertinib, if a patient is asymptomatic, you will start with osimertinib, fine, but you have not to delay the radiation treatment if the patient presents with CNS mets and you're going to start the patient on EGFR TKI, because it has been found that you should give the radiation treatment first, or if you have some neurosurgical intervention possibility or SBRT possibility, depending how the patient has presented with mets, that should be done upfront, and then subsequently the osimertinib should be started. This is just for the general information, because if you delay the radiation treatment with the context that the patient is going to, we should start as early this TK and the patient will have overall survival. But there are trials which have shown that if you delay the radiation, CNS directed treatment, be it surgical or radiation, and that is going to have that these patients' overall survival is poor as compared to the patients where you start the radiation and then CNS directed treatment. Then about osimertinib, we know the overall response, CNS response rates are very high, 70%, and you are expecting even the good thing about osimertinib, 24% of patients with CNS mets can have CR rates. And then besides the brain parenchymal, leptomeningeal mets also fare well with osimertinib. So there are different, next slide, please. We know that isolated CNS progression that can occur, as I discussed, due to poor EGFR TKI penetration into CSF, as compared to other TKIs. Osimertinib has 10 times blood-brain concentration. So this is the reason why this drug has effectiveness as far as CNS mets are concerned. And then we know that per se in the primary, if you consider lung upfront and if you consider the CNS met, the T790 mutations are, significantly, it is positive in brain mets. So this is another reason that osimertinib is effective. If you do the carbon 11 labeled FDG PET, we know that the concentration of this drug achieved in the, CSF or it is very high. So this is the reason that it scores over other drugs, that is a very high CNS response rates and even CR rates 24%, which is really good for a clinician. Next slide, please. So this is what I have already told you. If you compare in the PET also, you can see that the maximum, brain concentration achieved by any EGFR TKI is osimertinib. Next slide, please. Osimertinib has demonstrated high brain concentration, we know, as compared to other CNS drugs. So osimertinib has shown superior efficacy as compared to alertinib and geftinib in the CNS, and efficacy in patients with brain mets was not investigated in previous trial that I have told you. Afatinib showed a significant improvement in the systemic response compared with chemo, but intracranial response was not assessed. So if you consider the patients of EGFR mutation positive, then with upfront CNS mets or without upfront CNS mets, because we know CNS is one of the favorite site for later recurrence and relapse. So osimertinib fares well. Next slide, please. So osimertinib demonstrated a superior systemic PFS benefit regardless of CNS disease status at study entry. This is another important point. It's not that if a patient has underlying, this we have initially also discussed, that hazard ratio, if you consider in all patient subgroups, even if there are CNS met, it does not mean that the patient is not going to have a significant PFS benefit as compared to the patients without CNS mets. So the PFS benefit is maintained in patient subpopulation group of CNS mets. Next slide, please. So this is intracranial PFS. We know that again the osimertinib fares very well as far as CNS PFS, significant PFS. We know that it was 16.5 months in osimertinib arm, and in standard of care it was 13.9 months only. Next slide, please. This is CNS progression of first-line osimertinib versus standard of care. We can again see here that the CNS progression rates are significantly low with osimertinib as compared to other TKIs. So we should consider osimertinib as the frontline treatment, keeping this advantage of osimertinib also in mind. Next slide, please. So now, as far as NCCN guidelines, we know for newly diagnosed patients with non-small cell lung cancer, we know the approval for the brain mets in non-small cell lung cancer. Pembrolizumab in PD-L1 positive is there. Alectinib, brigatinib, and ceritinib for ALK rearrangement positive. We know that brigatinib has significant CNS penetration as well as CNS activity, and the nivolumab, and then osimertinib and EGFR mutation subtype. Next slide, please. So tolerability profiles of EGFR TKI. If you, next slide, please. We again have this. I have already mentioned that it has a very favorable safety profile despite almost double median exposure. That is 20.7 months versus 11.5 months. Despite significant PS, despite significant ORR, despite significant OS, which are significant as far as our clinical practice is concerned. The other advantage of this drug is definitely a safety profile is quite good as compared to the other TKIs. We can see that discontinuation rates are very low, and mortality and grade 3 and grade 4 side effects with this drug are significantly lower as compared to the other TKIs. Next slide, please. Now, if you compare the different, TKIs versus osimertinib, as far as the different side effect profile, we can still see that grade 3, grade 4 events are quite less as compared to the other TKIs, and the drug discontinuation rates are very low because of that. And naturally, the side effects, most of the side effects will be grade 1, grade 2, which are manageable, and they are not that severe, and mortality is also very low. Next slide, please. So dependent on this adverse event duration and severity, a dose modification of second generation TKI may be necessary to improve the tolerability. Whereas with osimertinib, this is not required. So drug dose modification with osimertinib is not required because most of the other TKIs have a very significantly bad, adverse event profile. You may require drug modification and even drug discontinuation because of the adverse events. Next slide, please. So this is the safety data. If you can compare the true trials, that is the Archer 1050 trial and the Flora trial, and we can here compare that in all terms of adverse event profile, whether there is serious adverse event, whether there is adverse event which causes dose reduction, discontinuation of treatment, or mortality. In all the parameters, it is the osimertinib which scores over the dacomitinib. So, or even geftinib, you can say. Though geftinib is better as far as tolerability is concerned as compared to dacomitinib, but it's not that tolerable as osimertinib is concerned. So, in clinical practice, we can safely score this drug also. Next slide, please. So, dacomitinib use in geriatric population. We know that yes, lung cancer patients, we have significant number because if you consider the population, geriatric population is significantly increasing in our population as well. So this will also comprise a big component of our malignancy patients, and especially in lung also, this is a significant proportion, especially more than 65 years and so. And we know that these patients, we are not that sure whether we should start first generation, even second generation TKI. When we start, we find that the tolerability of these patient subset is very low with these, especially with dacomitinib. It's out of question to safely start it in elderly population. So it has been found that more frequent discontinuation rates, 24% versus 10%, for adverse reactions in patients 65 years or older as compared to those younger than 65 years. More frequent dose interruptions, more incidence of grade 3, grade 4 adverse events. So as far as geriatric population more than 65 years, safety of dacomitinib is questionable. Next slide, please. So the quality of life, we know that. Other important parameters, especially in the trials, is that you have to compare quality of life. Quality of life, if you see in Flora trial, in all the parameters, if you consider in the quality of life, Flora trial has really shown, scored over Lux Lung 7, Archer trial. So a quality of life parameters is also very, excellent as far as Flora trial is concerned. Next slide, please. Next slide, please. So ultimately, it's important that why do we think that the osimertinib should be started in the first line? Why not in second line? That is also very important. See, ultimately, most of the people, we, especially in developed countries, we actually think because of financial constraint and other things, let us reserve this drug for subsequent lines of treatment because we know that is a stage 4 and recurrence, relapse, this is common. And then resistance to EGFR, TKIs within 1 to 2 years, if you consider conventionally, first generation, second generation, it is known within first to 2 years. And then why not to reserve this osimertinib for subsequent treatment? Why upfront only? This is a debate, but osimertinib has won this debate. Next slide, please. We know that actually when you start the treatment, actually at that time, most of the patients, you may at least 70% we can consider they are eligible for starting the treatment, isn't it? And subsequent for if you start the first generation TKI, the dropout rate is very high. See, because that 1/3 patients won't receive any subsequent treatment. And then if you consider T790 mutation status, 1/3 you don't know. And 1/3 patients, you have T790 mutation positive. And among the T790, next slide, please, positive patients, you will see that only 50% are eligible for receiving osimertinib. So weighted average PFS is 15 months with standard of care in first line, followed by no therapy, chemotherapy. Osimertinib, only 1/3 patients will be eligible. So even if you consider that geotag study, which will come in the mind, that afatinib followed by osimertinib showed a significant, OS, especially in terms of 41 months, but there were caveats in this trial. But the dropout rate who are eligible for subsequent treatment is very low. So next slide, please. This is what I was actually explaining. Dropout rate because of unknown status. Some patients are not able to undergo T790 mutation testing. Out of 50 patients who are T790 will be eligible subsequently. So if you consider initially there were 10 patients, that means only 7 at the end will be eligible. That is 1/3 patients will be eligible for second line osimertinib. So it's better to strike at the first. Next slide, please. So starting with prior EGFR TKI and then treating those that develop EGFR TKI with osimertinib, we have seen this. We have discussed this study previously. Next slide, please. So this is a retrospective analysis of patients who received first afatinib, then followed by osimertinib, and we have seen that GeoTag suggested reserving the osimertinib for second line treatment after failure of the TKI may result in a better OS. But in GeoTag, median OS for patients who received afatinib followed by osimertinib was significantly high, 41 months, but there are caveats in this trial. Next slide, please. So GeoTag has a high degree of selection bias and is not representative of the broader EGFR mutation non-small cell lung population. It was a retrospective study and excluded the patients who were T790 mutation negative, or who were not tested, or who died on first line afatinib and could not receive second line therapy. So the endpoints TTF cannot be compared with PFS and includes treatment beyond disease progression. So OS was exploratory. That's what I'm saying. They included multiple endpoints, and ultimately, unless they cross one endpoint and then they could achieve another endpoint. So this study basically has a lot of caveats. You cannot extrapolate this to your clinical practice. Next slide, please. So sequencing of EGFR TKI, it's not smart enough. We should not actually extrapolate this trial result to our clinical practice, because everyone will not be fit to receive this treatment. Only 1/3 patients. Next slide, please. So osimertinib is recommended for the treatment of metastatic EGFR non-small cell cancer. There is no doubt about it. Next slide, please. So in summary, we know that this is the best drug to start. 30% patients are able to continue this drug at 3 years, and it has shown a significant benefit in all subgroups. And at the end, I would like to tell you that now we have started with osimertinib as a first line. Most of the clinicians, wherever the patients are able to start this treatment, now we will be more encountering that compound mutation is one condition where you have common and uncommon EGFR mutation positivity. Even there, if you consider the common mutation along with the uncommon mutation, prognosis is still better. But if you have common mutation combination, it's still it is the best. But if you have combination of uncommon and uncommon mutation, then it is worst. Then if you start with the osimertinib, you have to see that subsequently the patient can develop the resistance, and at that time, now we have in certain mutations first and second generation TKI, we have amplification of MET, HER3 overexpression, and HER2 mutation positive, and then subsequently BRAF positive. This is again an important thing to consider: small cell lung transformation in patients on osimertinib, which will not fare well. So there are evolving options of treatment for patients who become subsequently resistant to osimertinib, and then this is for our learning that exon 20 insertion mutation, we have this amivantinib and we have mobocertinib. And for MET positive patients, you have savolitinib. This has been already discussed, but there is one more, lazertinib. Lazertinib is a third generation TKI, which has been also tried in combination with amivantinib in subsequent patients who develop resistant to osimertinib. Thank you very much.
Thank you, Dr. Altaf Ara, for such an excellent talk. Now we will move for a clinical based discussion on early lung cancer, and I would like to call my learned, experienced, multidisciplinary doctors. Ashish. Hello, Ashish. Yes, Ashish. Hello. Hello.
Yes, sir. Ashish sir is not there.
Okay. Now I would like to call my panelist, Dr. Dinesh Katyar, Senior Consultant and Head of the Department of Surgical Oncology, Venkateshwar Cancer Hospital, Delhi, Dwarka. Dr. Jyotika Jain, Senior Consultant and Head of the Department of Radiation Oncology Department at Venkateshwar Cancer Hospital, Delhi, Dwarka. Dr. Ankita Jain, Surgical Oncologist, Consultant at Venkateshwar Cancer Hospital, Dwarka. Dr. Saurabh Gupta, Senior Consultant, Surgical Oncologist at Venkateshwar Cancer Hospital, Dwarka. And all three speakers which previously discussed their topic is invited for a panel discussion. Hello, I am audible to everybody?
Yes, yes.
Sir, yes, sir.
So, sir, thank you very much, sir.
First of all, I would like to discuss this case with as a multidisciplinary approach. 67-year-old gentleman, non-smoker, presented with mild cough. X-ray chest shows a small lesion in the left upper lobe. By mistake, they mentioned about CT chest, but I would like to say PET CT scan shows a left apical lobe, and this is the PET CT scan report. You can easily see there is a left side, upper apico-posterior side, there is a tumor, and there is no node. Basically, it's a T1N0 disease. So the PET CT scan report shows a lesion in the left apico-posterior side with adjacent crural tag features as a primary neoplastic lesion. No other side lesion, N0 disease. The biopsy is adenocarcinoma of lung. The question is open to everybody. What next you will do? You have listened the three talks, the overview of lung cancer, the biomarkers, and by Dr. Altaf, the role of TKI in adenocarcinoma, those who are EGFR positive. Anybody can pick up this question, what they will do next if there is a adenocarcinoma, only T1N0 disease, what you will do next? Dr. Dinesh.
Yeah, in this case, there are few non-FDG avid lymph nodes.
Yes.
So I would like to do mediastinal staging.
Yes.
Method of endoscopic ultrasound or endobronchial ultrasound, and
Yes.
I will do, they are enlarged. I will try to
Yes.
do NAC to do the mediastinal staging.
Okay. Any special tissue sampling you require despite of adenocarcinoma diagnosis on a biopsy as a surgeon?
Yeah, liquid biopsy also will be good in this case, and
Any other lab test, any other investigation would you
yeah,
like
yeah.
to do?
In this case, I would like to do because it looks early stage. So, like
Yes.
pulmonary function test, I would like to do in this case for this patient. Even bronchoscopy is required in this case.
Yes.
Besides is like routine test I would like to do.
Okay. Dr. Ankita, as a
Yes.
surgical
Good evening, sir.
oncologist. Hello.
Good evening, sir.
Good evening, Ankita. As a surgical oncologist, this is a very early stage lung cancer, left-sided adenocarcinoma. As Dr. Dinesh clearly mentioned about that, he will go for a further test. You would like to add any other things for a lab test or a tissue sampling technique or any other investigation? Dr. Dinesh mentioned about he will go for a pulmonary function test like PFT.
So we can do EGFR testing on the tissue sample in early lung cancer cases.
Okay.
Apart from that, Dr. Dinesh has covered all the tests that we need
Yes,
for.
yes, he mentioned about the bronchoscopy, even the endoscopy, endobronchial ultrasound and other things.
Yes, sir. Because there are some non-FDG avid nodes, we can go ahead with staging so that we will have a better understanding of the staging pre-op.
Okay, okay, okay. So pre-treatment evaluation, would you recommend a MRI brain, Dr. Dinesh, or a CT? Suppose you are going for a surgery in this case. Would you like to go for a MRI or CT of brain?
See, if mediastinal nodes are not enlarged, they are negative, and it is a stage 1 disease.
Yes,
So
this is stage 1.
I will not prefer to do a MRI brain in this case because chance a PET scan is already done and there is no evidence of metastasis anywhere.
Okay.
So MRI brain, I would not like to do, and I will prefer in cases of stage 2 or 3 where
Yes.
is around 25%.
Yes.
In this case, I will not.
Means I totally agree with you that up to stage 1B, there is optional things only until as patient is symptomatic. And stage 2 onwards, you can go for a MRI. Dr. Ankita, any comment from your side?
Sir, I absolutely agree with this. As per both ESMO and NCCN guidelines, stage 2 and 3 MRI brain is compulsory and 1B is optional. But just considering today's day and age, I think we usually go ahead with MRI for almost all cases just for medical legal purposes. But otherwise, as per guidelines, I think this is absolutely correct that for stage 1A, we need not go for an MRI brain.
Means Dr. Dinesh mentioned about that there is some non-specific lymph node and any role of pathological oblique mediastinal staging in early lung cancer before advising the curative surgery. Dinesh, Dr. Dinesh,
Yes, sir.
would you like to go for a mediastinal staging workup?
Yeah, in this case, I will do. I will prefer to doing endobronchial ultrasound, and if they are enlarged, then I would like to do FNAC.
Okay. Not the mediastinal or
those are a quite invasive procedure, and so if they are enlarged, we can do endoscopic ultrasound also, endoscopic esophageal ultrasound or endobronchial. So I will not do the invasive procedure.
Okay. Getting the tissue sometime in such a early stage lung cancer is a problem. As you mentioned, if possible, then you should go for a liquid biopsy if there is accessible site. If you see the guidelines, they clearly mention about that you can go for a pulmonary function test, which you mentioned very clearly. The bronchoscopy, you mentioned about that. And consider the non-specific things. You should, by non-invasive methods, you can go for a mediastinal assessment. And you mentioned about the PET CT scan after this stage 1B onward. Your choice is the indication is after stage 1B. Otherwise, stage 1B is an optional one for MRI.
Yes.
So this patient basically has a US, no enlarged mediastinal lymph nodes. Means there is no lymph node in the mediastinum. Medically fit, underwent surgery. And the post-surgery, just see, patient is having a pathological staging T2N1, and out of 3, 2 lymph nodes were positive. Basically, the bottle 4, basically the 10 and 11, 2 lymph nodes shows a metastatic deposit. And as per the T2N1 is a stage 2 disease, what you will do next if patient is having a curative surgical resection by surgeon? Biomarker test. Dr. Muzamil, do you check any molecular biomarker, specific marker, or a NGS? You are inclined toward the NGS in the lung cancer. Even in early stage lung cancer, would you like to go for NGS, Dr. Muzamil?
Sir, first of all, about this patient's surgery that has been done, and if we see the histopathological T, it is almost T1 as
Yes.
per the size is concerned.
And I
But-
would like to show the picture. I would like to show
Yeah.
the picture of
Yeah.
the
But additional finding is that there is visceral this pleura involvement.
Yes,
that makes
yes,
T2.
yes,
Otherwise,
yes.
it
Very
is
specifically
otherwise
mentioned
it is
about that.
yes. Otherwise, it is T1C. And if we take that out, this visceral, and this is N1. So it becomes stage now 2A. With that
Yes.
T2, it becomes a stage 2B.
Yes.
So early stage disease, and I won't advocate post surgery. Yes, we don't have to do EGFR testing in biopsy specimen. We have to do the EGFR testing in surgical specimen because we
Yes.
don't know what stage it will come. So after
Yes.
surgery, you are saying that it's stage 2 disease. Now here, NGS is not advocated. Clearly, because we don't have so guidelines so far that if ALK will come positive, that you will go for the ALK-based adjuvant testing. Yeah, ALK-based adjuvant treatment. Yes, EGFR is positive. You have a data. Adura trial is there at your back
Yes.
that you are
Yes.
going to give the adjuvant treatment for 3 years or osimertinib.
Yes.
Or PDL1. Yes, another is that PDL1, as Dr. Nadeem also showed,
Yes.
we should do PDL1 plus EGFR if patient is qualifying for either immunotherapy or TKI-based treatment, not NGS.
Okay. Dr. Nadeem. Dr. Nadeem. Hello, Dr. Nadeem. Dr. Ara. Hello, Dr. Ara.
Sir, Dr. Nadeem and Dr. Alfatara is not there. Somersetburg there is not.
Okay. So next question is, do all patients with early lung cancer stage 1 to stage 3 undergo surgery? Dr. Dinesh? Dr. Dinesh?
Yes, yes. Up to 2 surgery is advisable, but for 3, I would prefer some neoadjuvant treatment.
Okay. If there is no bulky disease, still you want an NACT? Dr. Dinesh, if there is no bulky disease,
it is quite resectable. We can go for surgery also.
yes. And if not, what percentage do not undergo resection if stage 3A?
We will see what Dr. Saurav has got opinion on this case about this, if he is there.
Dr. Saurabh, Dr. Ankita?
Sir, I think it depends a lot upon the resectability. It depends a lot on the patient fitness. So we would put these patients through a multidisciplinary tumor board and take a decision accordingly in case of absence of any bulky disease. If it is resectable, we surely can go ahead with surgery. But definitely, we have
Bulky
to
disease,
keep
my
an eye.
choice is the NACT. Means if N2 disease, bulky, my choice is NACT. Means
Definitely.
whenever there is no bulky disease, the question is 80 to 82% patient, you can say you can go for a surgery without any problem. Yes, in roughly 20% of the patient, you have some difficulty, you need a NACT.
Right, sir.
Means as a surgeon, the question is open to both of the surgeon. What factors should be considered in determining resectability of the lung cancer? Dr. Dinesh, what factors you will see that patient is resectable? And Dr. Ankita, this question is open to both of you. As a surgeon,
Sir, it will depend on the fitness of the patient.
yes,
And Or basically how much resection is required, whether the patient will have to go a lobectomy or a bilobectomy or a sleeve resection, or in some cases a pneumonectomy might be required.
Basically, more if mediastinal structures are involved, or if there are no plane with mediastinal like aorta or pulmonary, then these patients, we should avoid surgery.
Okay, then we can go for a chemo RT in such cases.
Yeah.
Okay. Now once you are talking about chemo RT, Dr. Jyotika Jain is here, and she will tell us about role of radiotherapy in early lung cancer, and basically the role of port in early lung cancer, where the disease is T2N1, and basically role of SBRT in early stage lung cancer, which patient received this. Dr. Jyotika will tell us regarding this question. Dr. Jyotika Jain.
Thank you very much, sir. So basically, all the patients who are, it is a post-op case T2N1, where all resected margins, if they are clear, there is no role of RT in that case. But if patient is surgically not operable, if somebody says surgery is not possible, in those cases, we would like to go for local radiation with concurrent chemo. Now coming to SBRT, if any early lung lesion is there, if if it is T1, T2 lesion up to 5 centimeters, and if all patient is fit, like relatively less fit as compared to surgery, those patients, they can be taken up for a stereotactic body radiotherapy, and that you tend to give very, very high dose of radiation in very short period of time. Like in this, you give ablative doses. That is why it is called SABRT also. So like 6 to 7 gray or 10 gray per fraction in less than 5 fractions. So normally treatment gets over by 1 to 1.5 to 2 weeks, and that gives really ablative dose, and local control rates, they are to the tune of 85 to 90%.
Dr. Jyotika, any role of endobronchial radiotherapy in lung cancer patients?
So in any patient who is having hemoptysis, or like nowadays we are having very well-defined targeted radiation, even through external radiation also. But if any growth which is obstructing the lumen somewhere, I'll say mainly in more advanced stages, and if there is hemoptysis, in that case, you can go ahead with intraluminal brachytherapy. But nowadays, as we are well equipped with external beam radiation, and we can give high dose of radiation even externally, even that leads to most of the times opening of the collapsed lung in the distant part, distal to growth. So even external beam RT is another option. But if any frank growth is there intraluminally, which is concentrically involving the lumen, in that case, we can go ahead with the intraluminal brachytherapy.
Dr. Jyotika, Dr. Dinesh and Dr. Ankita mentioned whenever there is a mediastinal involvement, they prefer that they will not go for a surgery, or if they will go for endobronchial ultrasound and FNAC is positive, then most of the time we are going for a CT-RT. If there is a bulky disease, still you go for a CT-RT, or would you like to go for a NACT in such situation and then go for a CT-RT?
So if it is encompassable in my radiation field, and I am able to deliver the required dose to the patient, in those cases, I would like to go for local radiation with concurrent chemo. But if it is
even in a bulky disease, even in a N2 bulky disease,
in N2 bulky disease, N2 bulky disease also, if it is encompassable. But if it is non-encompassable, definitely I will go for NACT.
Okay. Any role of a adjuvant radiotherapy in lung cancer if the Dr. Katyar or Ankita did a complete surgery? What are the indication of a adjuvant radiotherapy post-surgery, Dr. Jyotika?
So post-surgery, if all resected margins, they are negative, there is no role. If it is R1 or R2 resection, in both the situations, there is role. even in that, there are two choices. Either we go for resection and chemotherapy or CTRT. Definitely in R2, definitely CTRT. And if it is R1, then both options are there. Either we can go ahead with chemotherapy followed by targeted agent, and or resection followed by chemotherapy, or second option is RT along with chemotherapy.
Dr. Dinesh, are you agree with Dr. Jyotika? Suppose there is a margin positive and you completely remove everything, but the margin is positive. Would you like to go for a resection of again surgery in lung cancer?
No, that is not feasible most of the time, because field is so vast that we don't know exactly which side is positive, where to go, and particularly in the lung, little whatever is remaining, we are going to injure it further. So
So I
resurgery,
mentioned, sorry.
resurgery is difficult.
So
Resurgery is
actually,
difficult.
I mentioned, sir, if it is possible. Otherwise, we'll definitely go ahead with CTRT in R2 and both options chemo followed by targeted agent. That is another option in R1.
Dr. Dinesh, can you give us idea regarding which type of a surgery routinely in lung cancer as a surgeon you are doing? Sleeve resections or a lobectomy or a wedge resections or a pneumonectomy or a lobectomy means an early lung cancer.
See, the most common is lobectomy. With lobectomy, patient is absolutely fine after surgery. But if we do pneumonectomy, patient is it is very difficult to manage those patients, because they become breathless after just walking and all that. So the gold standard is, if possible, lobectomy, and just little bit, if disease is just going beyond the fissure, you remove that part also. So basically lobectomy and the mediastinal node dissection is the generally standard therapy. And
Yes,
we
Dr. Dinesh.
by open method or by VAT. These days, because it is easy to do by VAT, video assisted thoracic surgery, so VAT is preferred.
Yes. Dr. Ankita, the
Yes,
visceral
sir.
flora is involved in this, and Dr. Dinesh mentioned about VAT.
Right, sir.
So what is your opinion regarding the open versus VAT surgery, video assisted thoracoscopy and surgeries?
So definitely VATS is preferred in patients in whom it is easily resectable. In cases where there are multiple adhesions, or there is basically, if where VATS would become difficult, I think very rarely open surgery is done now, or unless there is too much bleeding or intra-op complication where we have to convert to open surgery. But definitely VATS is preferred over open, as said by Dr. Dinesh.
Okay. Means, Dr. Muzammil, people are talking about a neoadjuvant chemotherapy in a bulky disease or advanced disease, or a one surgeon feel that they cannot operate. Means, as a medical oncologist, role of neoadjuvant therapy in early lung cancer. Nadeem shows some data. What is your opinion?
Yes, clearly, if a surgeon in multidisciplinary board, patient is being discussed and surgeon says operability is borderline, so that time neoadjuvant chemotherapy. And we have seen that whether you give neoadjuvant, whether you give adjuvant, the survival is same. There is no difference. But only thing is that post-operatively, most of the patients they are not able to receive adjuvant chemotherapy. So in that scenario, neoadjuvant is good.
Means, what is your choice? The nivolumab or the chemotherapy drugs like
No,
minoramine or
I have not used the neoadjuvant nivolumab so far. Whenever I have used platinum-based chemotherapy only.
Okay. Means, Dr. Muzammil, there is a stage 2 adenocarcinoma. Would you like to go for a NGS, or you go for a 3-test EGFR, PDL1 and routine ALK to see the early changes, and if required, because the other are less than 2% positive?
Yeah, not NGS. There is no data, but that can be
Yes,
done on academic purpose only. But
yes,
for practical purpose, it is EGFR and PDL1.
EDL1. Role of adjuvant chemotherapy in such patients, which I have discussed with you.
Yes, as same as that of the neoadjuvant chemotherapy, there is a role of the chemotherapy in stage 2 disease, not in stage 1 disease. And most of the stage 1 disease patients are observed unless and until there is some high risk features. Otherwise, yes, stage 2, stage 3 disease operated patients, adjuvant chemotherapy is to be given. But if they have EGFR positive, as from the ADIRA trial, and in that case, yes, you can skip adjuvant chemotherapy. You can directly go to the adjuvant osimertinib for these 3 years. And it has been seen that in ADAURA trial that 60% of the patients, they received chemotherapy followed by this osimertinib, and 40% did not receive any chemotherapy. They directly received osimertinib for 3 years. So if we see the hazard ratio for both, it is almost equal, 0.16 and another was 0.20. So
Yes.
80% disease-free survival, otherwise also at 3 years. So there is no difference. But from practical purposes, stage 3 disease, it is better to give chemotherapy, give 4 cycles of adjuvant followed by osimertinib. It's a stage 2 disease. You can leave this chemotherapy part.
Please suppose there is a stage 1B and there is a high risk. The
Yes,
poorly differentiated and the pleura is positive, visceral pleura is positive, or there is a vase resections. Would you like to go for a chemotherapy or this adjuvant TKI only, third generation?
you are saying, sir, stage 1B disease. For stage 1B disease, I will not give chemotherapy.
Yes.
Definitely, I will not give chemotherapy.
Okay. Any benefit of chemotherapy in adjuvant setting in stage 2?
It will further, yes, it will further add another 3 to 5% maximum.
Yes. And drug combination, which is your choice?
Yeah, adjuvant as well as neoadjuvant, it will be vinorelbine cisplatin based. That has been proven.
Yes, yes, yes. This is the basically the stage point of view, and we have already discussed this. Yeah. My question to all of you is, what are the recurrence pattern in our patient with early stage lung cancer, local versus metastatic disease? Dr. Dinesh, suppose you did a curative surgery, what are the chances of recurrence in such patients?
Most of the time I have seen recurrence in metastatic disease form rather than local recurrence.
Okay, 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 okay.
Maybe
Dr.
in the
Jyotika.
brain or bone.
Dr. Jyotika.
Sir, it's I'll say both like local as well as regional, like metastasis. You tend to see both the sides.
Dr. Jyotika, is any difference in radiation therapy of left-sided versus right-side lung cancer? Left side, there is a heart.
Yes, sir. Normally, now there is a way like you tend to, where is the location of the tumors, depending upon that, you are having gating facility, like you can have motion management in that, like deep inspiratory breath hold technique. You can make the dose to the heart lesser by this technique. This technique we are having and we are using in many of our patients. So by this technique, DIBH, deep inspiratory breath hold technique, you can have expansion of lungs and you move the heart away from the lesion and chest wall away from the lesion. So that decreases the dose toxicity to the heart as well as lung.
So this is the basically the NCCN guideline which we have already discussed, and thank you very much for your discussion part. Means I thanks all the faculties and the participants in this scientific program, and hand over the mic to the AstraZeneca person who will give vote of thanks to all of you.
Fine, sir. Thank you.
Thank you very much, sir.
Very much, sir.
Thank you,
And
sir.
thank you all attendees to join this meeting. And over to organizers.
Thank you everyone for joining for today's evening, and good night, everyone. Thank
Good night to everybody.
you. Good night.
Good night.
night.
Thank you very much, sir. Thank you.